Welcome. Today we're focusing on hemolytic uremic syndrome, HUS for short. We'll use a clinical case to pull out some key insights.
Yes, and for anyone working in healthcare, especially with kids, recognizing HUS fast is, well, it's incredibly important. It can really change things for the patient.
Okay, let's jump right into the case. Picture this. A 4-year-old comes into the emergency department. They've had bloody diarrhea for 4 days, seem really lethargic, and aren't producing much urine. That should set off some alarms immediately.
Definitely. And on exam, this child looked acutely unwell. Signs matched that reduced urine output story. Then the labs really started painting the picture.
What did they show?
So the complete blood count, hemoglobin was down to 7.9 grams per deciliter. Platelets were low, 48,000 per microliter.
Wow, okay.
Creatinine was quite high at 2.3 milligrams per deciliter, and lactate dehydrogenase levels were up. Urinalysis backed up the acute kidney injury finding, and importantly, no history of relevant drug use or lupus.
Yeah, that clinical picture plus those specific lab numbers, it just screams HUS.
Yeah.
And with the diarrhea first, it sounds like typical HUS.
Exactly. Textbook.
But can you explain a bit more about what's actually happening? That term, microangiopathic hemolytic anemia, what does it mean physiologically?
Think of it like this. The tiny blood vessels get damaged, and as red blood cells try to squeeze through, well, they literally get torn apart, shredded. That causes the anemia, the low red cell count, and you see these fragments, Schistocytes, on a blood smear. It's a systemic microvascular injury.
So if that's the mechanism, what are the absolute must-haves in the lab work? It kind of boils down to that classic diagnostic triad, doesn't it?
It does, precisely. First, that microangiopathic hemolytic anemia, you'll see signs like elevated indirect bilirubin in those schistocytes we mentioned.
Right.
Second, thrombocytopenia. That's the low platelet count, like our patient's 48,000.
Okay.
And third, acute kidney injury, shown by that high creatinine, the 2.3 milligrams per deciliter in this case, and the reduced urine output.
And typical HUS, that makes up, what, about 90% of cases?
Yeah.
Often after an infection?
Correct. Usually post-infectious, very commonly linked to Shiga toxin-producing E. coli 0157.H7. You see it in kids after bloody diarrhea.
And interestingly, fever is often absent when they first present.
That's a key point. Fever isn't typical at presentation, but you do need to watch closely for neurological signs. Irritability, maybe drowsiness, even seizures. These can be subtle early on, but devastating.
And that differs from atypical HUS.
Big difference. Atypical HUS, or AHUS, isn't linked to diarrhea. It's often related to the body's complement system, part of the immune system going awry. This complement dysregulation means it attacks healthy cells. That's why AHUS is often more aggressive and might need specific treatments targeting that system, like eculizumab.
So given how serious this is, what's the diagnostic plan? What tests are essential?
Okay, number one, complete blood count with the peripheral blood smear. You need to look for those schistocytes. Check lactate dehydrogenase. It's usually high because cells are breaking down, and haptoglobin, which will be low. A Coombs test should be negative.
Okay.
And definitely a stool culture. You need to look for Shiga toxin-producing E. coli. If you're even thinking about atypical HUS, then complement studies are needed.
Once HUS is confirmed, or even just highly suspected, what are the immediate management steps?
Well, supportive care is key. Dialysis might be needed if the kidney injury is severe or there's fluid overload.
Right.
And here's a critical point. Differentiating HUS from TTP, thrombotic thrombocytopenic purpura. It's crucial because treatments differ.
How do they mainly differ in presentation?
Broadly speaking, HUS hits the kidneys harder. TTP often has more pronounced neurological involvement. Getting that distinction right is vital for the patient's outcome.
Understanding HUS by walking through a case like this, seeing the presentation and the lab results line up, it really solidifies things, especially for something that moves so fast.
Absolutely.
Yeah.
So if there's one key thing to take away, it's this. If a child presents to you with acute kidney injury and anemia,
yes,
always ask about recent diarrhea. Always. Making that connection early is paramount for getting the diagnosis and starting the right care quickly.
That's a powerful takeaway. Definitely something to keep front of mind in clinical practice. It can make all the difference.